Hello and welcome to HTA Informing Innovative Drugs Market Access in LMICs, a webinar presented by the Developing Countries Interest Group of HTAI. For this webinar, a question and answer period will be available at the end. To participate, please submit your questions through Slido. A link to this will be posted in the chat for you to access. Thank you for your attendance, and we hope you enjoy this webinar. I will now hand over to Yanni Mueller.
Thank you, Bryce. Welcome, everyone. Good morning, good afternoon, good evening. I'm the current chair of the HTA in Developing Countries Interest Group, and as Bryce said, my name is Yanni Mueller, and I just wanted to provide you a little introduction to our interest group. It's a group of members of HTA International with whom we share experiences, discuss needs and challenges, and raise awareness in HTA in countries where there are no HTA but is being developed, and also share educational and training possibilities like through this webinar, or collaborate on different projects. You will see here the link to our website, and also ways to join HTI or the interest group. And then so if you have a topic that is of interest to you, please send me a mail or post it in the chat, and we'll take it up further in the other webinars that we are planning for this year. Thank you, and enjoy the series and enjoy the session today. Thank you.
Okay, so welcome to HTI Developing Country Interest Groups and the webinar. And today's webinar, our topic is Health Technology Assessment, Informing Innovative Drugs Market Access in Low and Middle Income Country. I'm Ying-Yao Chen from Fudan University, China, and I'm very happy to moderate this webinar. So I think the WHO identified achieving universal health coverage as a strategic priority, so which encompasses a full range of essential health services and also essential medicine and technology. It's a significant challenge for many countries, especially low and middle income countries, to increase their use of scarce public resources to ensure their citizen access to innovative pharmaceutical. So such a dilemma of high cost, limited access, and their universal health coverage is calling for innovative approach and solution. So this webinar, we invite three speakers and introduce and how to just make the innovative drug accessible and for the people. And then we invite two panelists to have discussed. And if you have any questions, and please just leave your note, and we try to answer your questions. So because the time limited, so I don't want to go too much. And first, I would like to invite Professor Jin-Hong An and talk about innovative drugs and market access in Korea. So that's a developed country, but we hope and we can learn some experiences and from Korea and experiences. I just very briefly introduced Jin-Hong An is a full professor at Ewha Women's University in Seoul, Korea, and also adjunct and fellow at the National Evidence-Based Healthcare Collaborating Agency, Seoul, Korea. And he is very active in HTI, in NATA, HTA Asian Link, and also ISPO. So Jin-Hong, please. And you have 10 minutes and a presentation. Thank you.
Thank you very much, Ying-Yao. It is my great pleasure to showing Korea's experience in this webinar series. So I'll go very briefly over the Korean system, the background, and go into the details. So in Korean system, we divide health technologies into 3 different tracks: drugs, medical devices, and diagnostics and procedures. And this procedure including all the medical procedure using drugs and medical devices. So there is a NECA, which is a research agency. So they generate HTA report. And we have the regulatory agency. So it used to be called KFDA, but now it's Ministry of Food and Drug Safety. And also we have the committee which deciding the diagnostics and procedures to be introduced into Korean medicine, called Committee for New Health Technology Assessment. And there is a reimbursement agency, Health Insurance Review and Assessment Service, HIRA. They have their own committee to decide that technology can be introduced into our health insurance. And our payer, National Health Insurance Corporation, they do price negotiation for the drugs. And for the other tracks, HIRA sets the fee schedule. And every decisions are finalized at the Ministry Supreme Committee. So we have a lot of committees, and that is the whole system. So for the drugs, they follow this specific path. So the company submit the dossier to HIRA, and the HIRA's review committee decides in 120 days for reimbursement. But the problem is HIRA clock only starts when they recognize the submitted dossier is complete. So they can send back to revise the dossier as many times as possible. So the companies are complaining the process is too lengthy. But actually, the legal time frame is only 120 days because it only starts after HIRA recognizing the submitted dossier is complete. So if they get positive recommendation, it goes to our payer, NHIS, for the price negotiation, including all kinds of the legal contract, such as a price volume agreement, risk sharing agreement, and some others. And then if they successfully finish the negotiation, then it is finalized at that ministry's Supreme Committee. And at each stage, when they fail to move on to the next stage, there are some other measures, such as Independent Review Committee, which was installed after Korea-US FTA. And NHIS stage, if they cannot agree on the price, then simply it is not listed, or the drug is essential, then there is a mediation committee. So some high-cost drugs are usually on risk-sharing agreement in Korea, and that is becoming popular. But our risk-sharing is only open to some drugs. So eligibility of the Korean RSA is limited only to the anti-cancer drugs, which is non-substitutable and non-equivalent drug existing. So all these non-substitutable and non-equivalent is interpreted in HIRA's regulation. So it is very technical definition there. And drugs for life-threatening rare disease also are eligible for risk sharing. Again, life-threatening is defined in HIRA regulation. And other drugs designated by the Drug Reimbursement Evaluation Committee, but it is very rare. And I do not recall any drug actually designated for this risk-sharing track. So risk-sharing agreement is popular because it is viewed as a solution for these expensive or innovative drugs. So just like many other countries, it is the solution to overcome the international reference pricing. So a lot of contract in risk-sharing agreement in Korea is financial risk sharing, so that there is a nominal price, but actually there is some financial rebate, which is calculated based on many different ways. So one popular way is setting up the budget cap, or they're setting up the percentage of the refund, or sometimes they're setting up the cap on the per patient cost, or any other ways, as long as our payer and the company agrees upon and putting into the legal contract, that can be possible. So there is a hidden discount which will not be revealed because just like many other countries, risk-sharing agreement is confidential between the payer and the company. So many high-priced drugs, they have a really high nominal price or sticker price, but actual transaction price will be after these hidden discounts, so which can be more reasonable level. So Korean generic drug price is transparently published online. Actually, it is a maximum allowable price, but almost 99% of the Korean drug transaction is at this maximum allowable price. So actually, this is more likely the transparent price. But the problem is this transparency generated many countries to reference Korean prices. So that's why risk-sharing agreement has been introduced in Korea to guarantee fast access to the innovative medicine. So risk-sharing agreement result in high published price or sticker price, which may help overcoming the international reference pricing, delaying access to the Korean market. So this is a list of some immuno-oncology drugs in Korea. Many of them recently reimbursed, and some there are restrictive indications approved. And as I know of, all the immuno-oncology drugs are under risk-sharing agreement. The content is confidential, but many discounts will be applied there. The current Korean system has some standoff problem, as I already hinted you, the lengthy review process, which has been criticized chronically by the industry side. So we do not have any system evaluating once the drug is reimbursed. So we have some policy change to lowering the drug price universally, but we never evaluated drug by individual basis for cost effectiveness or any other measure. But regularly, there are some policy to examining all the drugs existing, which may include some of the price review, but which is very rare or case-by-case situation. So that part generated Korean system concentrating on the first reimbursement stage. They are looking at very carefully, very lengthy, and try to lower the price as low as possible. So that's how Korean drug price got this fame of the very reasonable pricing. But once it is reimbursed, price is not reduced anymore until the patent expires. So that was the traditional Korean system. So how to combine this lack of price evaluation after reimbursement, because the actual drug price is changing over the time, plus all these complaints about the lengthy review process, and a lot of companies are complaining that there is uncertainty. HIRA is trying to lower the price based on that uncertainty. And some of the uncertainty cannot be answered because the drug is not introduced in Korean population. And if it is uncertain, the drug effects or drug efficacy in Korean population, which cannot be generated. So this is unofficial, so nobody is taking it yet, but suggested to our payer as a research report. So introducing new system of the post-reimbursement evaluation on these high cost or high budget impact drugs. So when they contract with the company side, they prepare research at that time. So they sign on proposed research of the post-evaluation, post-reimbursement evaluation, and they collect actual data of the effectiveness data from the Korean patient for a certain period of time, and then that data will be used to recalculating the cost effectiveness of the drug. So if any significant discrepancy is found, then it may enter into the new price contract. Otherwise, the initial price contract remained. or any other measures can be obtained for yeah.
Believe we may be having some audio issues.
Yes. Jinhong. Oh, okay. So maybe there's some networks and
Yeah.
lagging.
Perhaps perhaps we can move on to our next speaker while we wait for him to rejoin.
Okay. So maybe because Jinhong sent a networks issue. So maybe we just move to the second speaker, Deborah Algeria, and she will talk about cyber activism in diabetes and from Brazil and experiences. I would like to introduce Deborah very briefly, and a lawyer and a blogger and as an activist and the Master in Science, School of Public Health and University of São Paulo, Brazil. And so she has a lot of actually HTA public health and epidemiology and health economics and experiences. So Deborah, invite you to have your speech. Thank you.
Thank you. Good morning, good afternoon, good evening. I'd like to thank HTA for the invitation. I'm very happy to be here with you all. And I'm going to present the Brazilian experience of the fight of the patients with diabetes for access to analog insulin. I'm going to share my screen with you now. Can you see it?
We can see your screen, yes. Thank you.
Thank you. Well, diabetes is a condition, a chronic condition that occurs when the body can't produce or can use properly the hormone insulin. The International Diabetes Federation estimates that now we have almost 537 million people living with diabetes in the world. And this number is increasing, especially in middle and low income countries. Here in Brazil, we are in the 6th position of number of people with diabetes. We have almost 60 million people living with diabetes. And also we are in the 3rd position with children with type 1 diabetes. We are the 3rd, and considering the adults also, we have almost 1 million people living with type 1 diabetes. And we also are in the 3rd position with the highest health expenditure due to diabetes. Here we have a public health system. In Portuguese is Sistema Único de Saúde, our beloved SUS, that offer universal access, full care, and equitable assistance to all the Brazilians. We have the system has as principles, as guidelines to its organization, the regionalization, preventive and full care, and especially social participation. So the diabetics receive healthcare and pharmaceutical assistance with supplies and medicines by the system, by SUS, and this including the insulin. Well, the insulin, last year we celebrated the 100 years of the discovery of the insulin, that occur an evolution of the technology, and now we have the insulin analog that has better outcomes, especially when low glucose, to reduce hypoglycemia, but the costs are very high. We have 3 major companies that dominate the pharmaceutical marketing, and here in Brazil, the CONITEC, that is the National Committee of Technology Incorporation of the Ministry of Health, estimated that the fast-acting analog insulin costs 150 times more the price of rapid insulin, that is the standard, and the long-acting analog insulin would cost to the system $670 million American dollars in 5 years if incorporated. Well, so how we fight for this incorporation in this situation? I present here experience of the cyber activism in diabetes. When we talk about cyber activism, we are talking about hybrid actions online and offline of people or group of people, organized or not, seeking for social transformation, in that case for health rights. So the cyber activism in diabetes relates to people with diabetes fighting for their rights, for our rights to health. And here I have in Portuguese, of course, but we have here, I'll explain. Here we have dissemination of the public consultation. Here, the most of the time, the firm we participate in the discussion of HTA is by public consultation. So here we have a dissemination, the patient disseminating the public consultation. Here we have in Facebook. Here we have a conversation in Twitter, controlling the regularity. Here the committee didn't have publicized the report for the society to understand the incorporation. So I was talking to them, please publicize this report for us. This we have a kind of explanation how to do a testimonial for the public consultation to the patient. So we are trying to qualificate this participation of the patient. And here we are patient is encouraging other patients to participate in the public consultation. So what we observed, what we experienced in 2 occasions, we had first an evaluation of fast-acting analogs in 2017, and after the long-acting analogs in 2019. So in both cases, we have an original unfavorable recommendation from the National Committee of Technology Incorporation, because there are poor scientific evidence of the better outcomes of the analog. But in the first scenario, in the first case, they are only analyzing as a relevant outcome the glycated hemoglobin, that is the gold standard of diabetes control. But when they read our testimonials, we only talked about hypoglycemia, because it's the hypoglycemia that is our daily problem, is not exactly the glycated hemoglobin. So in that occasion, we had 974 testimonials. We could make it. The fast-acting analogs were incorporated to the health system, so we could guarantee the insulin for all, because before only people with legal action could access the insulin. But when they were analyzing the long-acting analogs, they include, because our testimonials talked about so much about hypoglycemia, they include the hypoglycemia as a relevant outcome to be evaluated. And so we had much more testimonials, and the protocol of type 1 diabetes that was created with the first evaluation was supplemented, and we could get full care. Well, what are the achievements and our challenges now? Well, with this participation, we could include the patients as active subjects in health relations. We could make the public policy closer to citizen needs, and also we make it a kind of qualification of the patients as social actors of our system and in control of the HTA process regularity. The challenges, the main challenges, that are much challenges, but I think the three most important are the high cost of medicines and low budget of the health system. Now we have our budget is frozen for 20 years. The provision in the health system on legal time after incorporation, because there are the law says 120 years before the incorporation, the medicines must be in the system, but it doesn't occur this way. And also now the COVID, also all this considering COVID-19, hunger and food insecurity. We have here almost 85 million people in this condition, and unemployment. We have almost 15 million people unemployed, but we have to fight. And this here, I think I finalize with the phrase that is in my research here, the QR code. You can know better my research about the cyber activism in diabetes, and we fight for lives, not for likes. Thank you very much.
Yeah, thank you, Deborah. Actually, using the digital and just kind of technology and just promote the diabetes and the medicines utilization, but the challenge is just the high cost and limited budget. And I think that we maybe discuss it later. Jinhong, and welcome you back. And I think we can give you 1 minute and 1 or 2 minutes, and just finalize your talk. And I think you mentioned those kind of innovative and real world evidence. And but then that's the picture frozen.
Thank you very much for giving me another chance. So the current system, all kind of the uncertainty sent back to the sponsor or the company to revise and resubmit. And if they cannot, it influences their proposed price to be lowered. But under the reformed plan, basically those uncertainty can be postponed to the post-reimbursement evaluation. So there will be a list of assessment items from the uncertainties. Then they can be reviewed after reimbursement. So it is also related to the NECAS. NECA has a clinical research funding for the public decision purpose, and it can be nicely linked with this budget to collect the data for very important items. And actually, they are doing it right now. Also, HIRA has some intention to collect the real-world data set to be used for all those research. So in Korea, the focus is going to collecting the real-world data to how to improve decision-making for these expensive drugs. And one solution proposed was we evaluating those expensive drugs after the reimbursement. So introducing new system to the Korean system, which lacks any post-reimbursement evaluation. So combining with the real-world data and then this new system change to overcome the high cost in our country. Okay, this is end of my talk, and thank you very much.
Yeah, okay, thank you, Jin-Hong, and give us a very whole picture about Korea, and so maybe we have a question to you later. And okay, so the third speaker will welcome Solomon Meyer, and her topic is cancer drug access and part health. And Solomon is Cancer Alliance and South Africa, and she is the project manager Access to Medicine campaign, Cancer Alliance, and the independent cancer advocate and activist for 25 years. And so, Solomon, please give your presentation. I will just show your slides.
Thank you, Jinzhou, for
Sorry. This one. Can you see the screen?
Yes, if you can just, that's it. Thank you.
Yes.
Thank you very much. Good afternoon, good morning, and good evening to everybody on the call, and also my appreciation to HTA for this opportunity to share the experience from South Africa. So lately we've heard a lot about the COVID access apartheid that has been happening with regards to low middle income countries. However, this issue was highlighted by myself already in 2018 and 2019, when I in fact already referred to cancer drug access apartheid in a previous presentation that I made. So next slide, please. South Africa has got a two-tier health system and is possibly one of the most inequitable in the world. And particularly if we start talking about the private sector, 16% of the population have got access to 84% of the healthcare professionals. And this is also very particularly in cancer as well. So it's not just for other diseases, it also plays out in cancer. And 84% of the population have got access to the 16% of the healthcare populations of professionals. Next slide, please. And Nelson Mandela was very definite when he actually coined it by saying health cannot be a question of income. It remains a human right. And I think that is the challenge that low middle income countries are facing today, with the majority of unaffordable medicines, and the question whether they will ever, in fact, have access to these medicines. And that's why discussions like today is actually very important for us to discuss the role of health technology assessment and how that should improve, in fact, access and affordability. Next slide, please. In 2017, the Cancer Alliance, with funding from the Open Society Foundation, actually investigated the patents on 24 cancer medicines. This was a very landmark report for us, and it gave us the opportunity to focus specifically on the cancer medicines that have got patents on it. And those were the aspects that we looked at: affordability and accessibility. Next slide, please. And what we saw was that that very few of the medicines were actually available on the in the public sector, and already 10 of those medicines were already on the WHO essential medicines list. I'm going to use two specific medicines just to highlight the difference between the public and private sector in terms of access and affordability. We decided very specifically to focus on dedicated medicines. And I must be very open and honest. At first, I thought, oh, this is going to be an easy task. But in fact, it isn't, because challenging a system with inequities is in fact a very difficult challenge, and you need to work systematically, and that's what we have been trying to do for the last 4 years with the funding that we received from the Open Society Foundation. I'm going to close that part by also highlighting the fact that our funding for the Access campaign is actually coming to an end at the end of this month. And that in particular is another problem that we face in low middle income countries, is the whole issue of advocacy with regards to the access and affordability of certain medicines. So next slide, please. What we have seen is that patents block equitable access and leads to excessive pricing. And the first example that I want to use is that of Trastuzumab, which was already added to the WHO list in 2015. And our activist behind that, and all the face behind the campaign, was Tobeka Daki, who unfortunately died 2 years after diagnosis, never having access to Trastuzumab. And she was in the private sector. So that was specifically the situation for her. And next slide. So the next slide will basically give us the indication of the pricing of Trastuzumab. So at first we had the 18-month treatment cycle, and I used the current exchange rate. And at that time, the originator price was $22,000, and that's for the 18 months treatment, as opposed to the clone of the same company, which was made available to the public sector, meaning then that the private sector had to pay far more than what the public sector paid, because the clone was never made available to the private sector. However, when the biosimilars was approved, and that was after 2 years of reviewing the dossier. So one can in fact just kind of like say, well, let us hope that we can achieve what Korea is achieving for, in fact, reviewing dossiers. And certainly the WHO pre-qualification program is now also going to assist us in terms low middle income countries for the review of certain of the medicines. But I think the pricing schedule there is, that I'm showing there, is in fact very interesting. And I think that the very lowest price now that is available is then that of 322. So if we can then look at that pricing of how that has come down and to what it was, then one can certainly start asking the question But where was the health technology assessment? Why isn't it? And I think it's time then to say that in South Africa, health technology assessment is not, in fact, something that is happening currently. So with the private sector, we use what is called by the Department of Health as a transparent system, the single exit pricing. And the only reason why they call it a transparent system is because the single exit price is transparently available to everybody, so it is public knowledge. However, it still is the company that decides what is the manufacturing price. And that is where in fact the problem lies. And if we go back to the clone her clon, that was very much a negotiated price. Only once the Trastuzumab was available on the essential medicines list, and that came in 2017, did it go onto the essential medicines list and therefore on government tender. So that's the kind of situation that we have, is that health technology assessment is not necessarily applicable for us in either of the two sectors. The second, next slide, the second medicine example that I would like to use is that of Linolidomide. So before 2016, there were already many generic versions of lenalidomide available globally on the market. And in South Africa, our patients were able to access that medicine through Section 21 authorization for the price of $325 per month. However, next slide. In 2016, the originator company, and we all know that Celgene has got many secondary patents on that medicine, because the original medicine was thalidomide. And after thalidomide came lenalidomide, and after lenalidomide came pomalidomide, and they've got extensive secondary patents on that medicine. Once that medicine was registered with by our regulatory authority, the medicine was then available at $4,886 per month. That is a substantial difference between the generic pricing and the originator pricing. Next slide, please. Generic registration happened after 5 years. So it took our regulatory authority 5 years to, in fact, evaluate generic dossiers. However, what we now have is that because of our patent system, so our patent system in South Africa does not allow for patent scrutiny. Therefore, it is merely a depository system where you apply for your patent and it is awarded. Nobody screens for secondary patents. And there is no patent opposition. And with regards to compulsory licensing, well, we've never had a successful compulsory license case in South Africa brought to court, because it is plainly far too expensive to do it. So nobody actually wants to take it on. So what we have currently, yes, we've got 5 products that are approved. However, only 3 of those products have entered the market. And since the products have entered the market, and you can see there has been a substantial difference between price reduction from the originator to the generic products. And even with the generic products, in the last year, we have seen a definite price war between the 3 companies in terms of lowering the price. However, generic lenalidomide is still not available for our public sector that serves 84% of the population. And the reason for that, remains affordability. It is still unaffordable for our public sector to procure for the public sector. Again, that is where the issue is, where is health technology assessment? Should we not be able, we not actually implement something like that? And before I close off, I also want to mention the fact that medicines such as Keytruda, and I'm using the very specific name, the originator name, that remains and will remain, and I want to say for a very long time, not available in South Africa, and is only available to a very select few people in the private sector. We're busy finalizing a report on the private sector access to oncology medicines in South Africa, and it is very scary that only 10% of the 16% of the population that access private health care have got, in fact, access to high-cost medicines. And this is exactly, again, where you need to start asking the question, the role of health technology assessment. So there's a lot of promises that we have, that with the proposed national health insurance that is that is busy sort of like playing itself out, what the format will be and when it will be implemented. So lots of political decisions still, but also a lot of administrative decisions in terms of how will this be implemented, and then very specifically, how will high-cost medicines such as cancer, will that benefit when we start talking about value-based care and all of these terminologies that are actually in the realm of the pricing system of the WHO. The Cancer Alliance, thank you, next slide, and which would also be my last slide. The Cancer Alliance is at the moment then busy implementing what we call solution labs. And these are very dedicated discussions that we have with a small group of role players and stakeholders, where we want to garner specific solutions for our problems that we would then want to take to our National Department of Health to say, is it possible that we can look at cancer access for the future? Because our report that we published middle of last year in August highlighted that our cancer is going to increase exponentially. And in fact, that same I want to say a situation is in fact going to play out in the majority of African countries. So it is time that we start looking at the whole issue of access and affordability on a more regional basis. So there's lots of discussions that I think that, and platforms that we should use to garner solutions for our own countries. Thank you very much indeed.
Okay, thank you, Salem, and a lot of challenging and for the access to the medicine and the pattern and also the health system and also other issues. Okay, so then and we will have two panelists and just have comments and also in the interactions and with our speaker. The first is the WHO and the official Q Santai, and he is the work at WHO headquarters Department of Health Products Policy and Standard, and his work focuses on pricing policy of healthcare products. He was the author of WHO technical report on pricing of cancer medicine, and as well a technical lead and for the 2020 WHO guideline on country pharmaceutical price policy. Q, please.
Thank you, Ying Yao. So thank you all the speakers for very interesting presentations. I think by now everyone would agree that the high price of new medicines are affecting all countries now. So not only the lower income countries, but also in high income countries and the very wealthiest of countries there. So I think we do need to think about the pricing issue from a global perspective, because this pricing will not only affect access now, but also future access of medicine. So we must think about the implications of the current situations on future access of medicines. The first point that I want to make is that not all new medicines are innovative. So sometimes we want to label them innovative, but not all of them are innovative. In fact, there have been a lot of concerns raised about some of the newer products coming to the market not delivering a lot of value in terms of health benefits, and some of them could potentially be more harmful than the existing treatment. So the key message there is really, we shouldn't, we should use HTA. Hopefully, HTA could actually inform that very well, capturing the whether or not there's incremental benefits and or incremental harm, and then trying to find a price that's aligned with its value. But so we shouldn't pay for everything and at any price as well. And the second point is that sometimes HTA, when it's done properly, then obviously it's very, very good and it can actually inform decision making. But sometimes, it also doesn't actually fully capture the full opportunity cost of that listing. So we have seen various scenarios where it is considered as cost effective, but not affordable. Then, there are various eminent scholars who are actually discussed this in the literature. So I think it's from a basic level for people who are doing HTA on the ground, and including WHO recommendation, is to actually making sure that budget assessment and affordability is part of that HTA process. So it shouldn't be just about cost effectiveness threshold, and if it meets that threshold, it should be reimbursed. And on top of it, I think it's very important to recognize the voice of the patient. So it has to be a systematic, multidisciplinary approach. So in this sense, we have heard stories today from Deborah and Salome, how it is really important to reflect societal preference in how we allocate resources, how we manage our very limited resources, and what price to pay for them. And finally, the last point is that we shouldn't lose sight. Ultimately, it's all about patient access to medicine. So we shouldn't lose sight of that. So we should keep focus on the public health goals of all the assessments. It shouldn't be just about the very sophisticated modeling. It shouldn't be just about processes, but about ultimately bringing that medicines to patients. So at the moment, there's significant gaps, even in high-income countries, how we price medicines and whether or not it actually facilitates access. It shouldn't be just focusing on commercial goals. So sometimes, we almost defend, public sector's ways of pricing because we say, R&D is expensive. We say that, we want future useful medicines, without really clearly thinking about where that value chain, how that products come to the market in the first place. There's a lot of public sector investment in a lot of the innovations. So we must keep focused that the whole point of anything that we do and all the analysis we do is about patient access. And I'll stop there. Thank you so much, Inya.
Ying-Yao, are you there to introduce our next panelist?
I'm sorry, I'm mute. Okay, so because timing, and I move to the next panelist, and Muna and James Lindy. And so Dr. Muna is director of the HTA department at the Tunis HTA agency, and she is playing the leading role and in HTA implementation in Tunis with the establishment of the master and press process and practice. And she is also very active and in the INATA and the HTA and the vice chair of INATA, and also involving a lot of WHO, and that's the tags or panels. Okay, Muna, please.
Thank you very much, Xinyao. Thank you for HTAI for this invitation and also for the great presentation of all the speakers. So very briefly, I will try to speak from an HTA researcher point of view regarding the access to innovation. So as we have seen in all the presentation, the access to innovation, especially in the context of scarce resources, is a common concern between all the countries, especially between low and middle income countries. Ultimately, there are new technology which are offering an additional benefit and sometimes addressing issues or health condition which were not possible to cure before. But there is, of course, a significant budget impact, on the payer. So it's important to establish from the beginning health priorities. It's important to have tools like HTA to help prioritization and to help the prices negotiation. Otherwise, we will increase the risk of non-efficient investment, while there are many technologies that can be useful and will, unfortunately, will be left out of the benefit package. Some, other issues will ultimately arise, like access delays, which is problematic for the patient. For patient, for the health system, and also will be discouraging for from pharmaceutical companies. Some of the other issues that were also discussed in the last WHO pricing forum is also a consequence of delays in access to innovation, like the judicialization of healthcare and the access through courts, which leads to more inequity, which leads to the allocation of resources to technology without negotiating the prices, and of course to the disruption of budget planning. As it was very clearly presented by all the speakers, so of course health technology assessment is an important tool, a multidisciplinary, formal, systematic, transparent process using scientific and rigorous scientific methods and the best available evidence. Of course, like what was said by Ki, when it is well done. It is also a unifying process that allows all the partners to engage in a transparent discussion about the value of health technology. So it will ultimately lead to a more transparent, more evidence-based, and also the rationale behind the decision will be clearer to the public and to citizens. From the other side, in order to be able to do well HTA, it's important to have clear processes, guidelines for health technology assessment, and to engage all the partners. And that HTA recommendation capture different stakeholders' views, including, of course, in the very important perspective from the patient. From the other side, as you know, each country has its challenges for HTA implementation in terms of system structure, in terms of training capacities, in terms of the lack of structured data. But I think that it's important to work to overcome all these challenges, and so that they don't represent a barrier, to implement HTA and to move toward, a better evidence-based decision. As you know, HTA, of course, and as it was said by all the speakers, including Dr. An, it is a resource-intensive and time-intensive process. Dr. An mentioned the fact that companies were complaining about the fact that delays can be long, and that HTA process starts properly after complete dossier submission, which is important also. And to mention the fact that HTA doesn't only rely, on HTA doers, on an HTA institution, but it needs, a sort of partnership between, the HTA institution, the payer, and the private sector, and each one should play its role in this HTA process. I want also to mention that, of course, health technology assessment is not a miracle. It will not address all the access issues. It will hopefully inform and facilitate decision making. It will unblock probably certain situation, but affordability in low and middle income countries remains an important issue. So I believe that some other tools, like for example, horizon scanning, which helps to identify priorities and what is coming next, in the market, so that decision makers can have various tools in order to be able to choose among the technologies. Risk sharing agreements also, between the public and the private sector, reinforcing negotiation tools, going beyond health technology assessment and using, many tools in order to be able to have a consensus on prices, and having, also improving the access also to, to biosimilars would be a good, way to resolve all the access problems. To wrap up, so HTA mechanisms are important, but they have to be locally tailored. They have to be good, transparent, stable, and predictable. Increasing cooperation between the public and private authorities is also important, and we have also to explore all the possible pathways and tools that exist. Thank you. Over Yinyao.
Thank you, and Muna, and talk about a lot of the HTA and their method, process, approach, but also we need some conditions and to implement those kind of HTA and in different settings. Okay, so I think I know we're already on time, but I think we still can have a couple minutes and extension. So maybe because we collected several questions and maybe very briefly, we have one question and about to the Jinhong, and this audience would like to know and whether the rare diseases drugs are also capped via risk sharing agreement. Rare diseases drugs, whether it's capped via risk sharing agreement. Jinhong.
Yeah. So one of the conditions for one of the eligibility is for the rare drugs, which has a life-threatening condition. So there is some definition such as, I believe, less than 3 years of life remaining or things like that. And it's a rare disease. They are on the risk sharing eligible. Plus, also we have cost effectiveness review exemption for those drugs like a rare disease, which is very difficult to generate data. So they are also, we have the exemption system too. But the problem with the exemption system, actually, we had a symposium yesterday hosted by Hira, and I spoke there. Korean exemption is permanent. So once you are exempted from cost-effective review, there is no post-reimbursement evaluation. So you are completely reviewed for the rest of the patent life. And that's not correct. So that's why the HIRA is also thinking, and we had a symposium yesterday, rare disease drugs introduced in Korean National Health Insurance, exempted from cost-effectiveness review, and how to reform the system to have those drugs, basically cost-effectiveness review after reimbursement.
Okay, thank you, Jinhong, and the answers. And I also have a question to Deborah. And I would like this audience would like to know what are the main challenges to the participation of patients and in the HTA process in Brazil?
Well, the HTA process here is the participation is only online. But we don't have universal access to internet here. There are issues on this matter. So for me, this is a question: how to promote the participation without promoting the access to internet. And another challenge maybe it's the to amplify or something that I think it's necessary to amplify the discussion with the citizens, because on the committee there are only one member as a patient, as a citizen representative, that is the National Health Council. But I think that it was necessary to be more patients participating in this discussion, in the decisions, in not only being consulted with must or not must not be accepted by the government.
Yeah, I think that not just the patient participate, but also should empower the patient capacity and involving the HTA process, and just
yes, another. Okay. As another thing is it's a complex microsystem. HTA it's complex to patient and citizen understanding. So there must be a simple language, I don't know, a way to explain so we can participate better.
Okay, thank you. Yeah, and here also have a question to Salem, and you mentioned in South Africa, like public and private sector actually is a totally different stories. Yeah, this and the audience think maybe a public and private sector that's kind of a health services system is yeah, actually HTA cannot do too much on those kind of inferences, those delivery system. So what do you comment on that?
I suppose, yes, that is very much the situation at the moment. However, I do think that we have not, with our proposed national health insurance, the actual framing of cancer benefits and how will the public sector or the private sector actually, in fact, access the national health insurance. All of that is still very much under discussion. And I suppose only once we have sorted out those boundaries and the parameters will we be able to then start looking at what is the specific role that health technology assessment can do for us. I do understand from the Department of National Health, Dr. Nicholas Crisp, that yes, there are already talks about health technology assessment agency and how one can start bringing that in to the whole realm of access and looking at specific medicines. Us as the Cancer Alliance will then also start pushing for that discussion very specifically to start happening relating to cancer access, and then see if we can add the rare diseases to us. So I think that the example that was shared from Korea is perhaps something that hopefully our government is actually having a look at and saying, you know, if we have to establish an agency, what will it look like? What's the role, and who's going to do that?
Okay, so Solomon, thank you. So maybe I have the final question and to Muna, and I saw the queue maybe just off the line. And so Jing Hong and just present the career HTA system. That's he used the words institutionalized institution. So so what do you comment on that? And those kind of HTA institutionalization, and so push the HTA development. But in the developing countries, sometimes those kind of context is not so easy to push HTA forward. So what do you give some recommendation to low and middle income country to start their HTA activities? Mona, please.
Okay, I think it's very important to have institutionalization or even a legislation, because our experience with HTA link, many countries suffered when the political regime changes. Basically, the support for the HTA is also changing, and which is not really healthy to maintain our HTA activities. throughout our network, we help each other. We do HTA advocacy to the other countries. Look at the Korea, we are successful here. And when in Korea is in danger, we mentioned like other countries or the other region. So basically, the legislation or institutionalization is very important to maintain the HTA activity. It is not easily removed from the existing healthcare system. So I strongly recommend to have a legislation or some agency established for the more permanent HTA activities.
Okay, Jing-Hong, thank you. Muna, do you have any comments or recommendations?
Yes, of course. I mean, yeah, so I will speak from, the perspective of an agency that started small and is growing over time, like my agency INEAS. I think it's important to start small, with the staff you have, to work on having, on building capacities for the internal staff, but also for the environment and also for decision maker and all the partners. I think it's important to build, since the beginning, clear processes, to tailor the methods of health technology assessment to your context, its requirements, and also its capacities. It's also important to engage in a continuous conversation with all the partners, especially the private sector, the payer, and I would say above all, it's important to convince decision makers and to work also on legal texts so that, HTA, which, for example, starts now in Tunisia, as on an ad hoc basis, will become, a systematic process for all the innovative drugs. And good luck for all the countries that are working, on HTA implementation right now. I know it's not something easy. Over.
Yeah, but you share the journey and to HTA, and I think that's also just helpful for all our audience and to know and to think about how to push the HTA development. Okay. So yeah, that's Yanni. Would you have any comments? And finally.
Thank you, Yin-Liao. Please go ahead.
Okay. So yeah, I think we're already over time, but I'm very happy to moderate this DCIG's webinar, and appreciate all the speakers and all the panelists. And I think this is just the first webinar and by the DCIG, and then we will have the other one and maybe 2 or 3 times and the webinar and in this year, and focusing on universal health coverage, and also maybe the patient preference and how to measure the patient preference, and using the research and some solid and the methodology. Okay, appreciate and HTI and all the speaker panelists and the contributions, and also appreciate our audience. And okay. Our webinar is just closed, and see you next time. Bye-bye.
Okay, bye-bye.
Jing-Hong and Muna, Yanni and Deborah, Salam, thank you. Bye-bye.
Thank you. Bye.
Bye. Thank you.
Okay.
Thank you. Bye-bye.
Appreciate and HTI and all the speaker panelists and the contributions, and also appreciate our audience. And okay, our webinar is just closed, and see you next time. Yes.
Thank you, everyone. Thank you, Neil. Bye.
Bye-bye.
Thank you.
Bye.
Bye.
Muna,
Bye. Thank you.
Deborah.